All right, so this next panel is called Non-SSA Program Interactions, and it's, as we all know, there's lots of programs out there that affect the likelihood that people with disabilities will participate in Social Security, disability insurance, and SSI, and we also know that there's lots of programs that affect the well-being of beneficiaries. And this panel today will look at interactions between the Children's Health Insurance Program and SSI, Medicare Part D, and its effects on the well-being of DI beneficiaries. And I'm forgetting the middle one. Kids who use vocational rehabilitation services in their long-term employment and Social Security disability and program participation. So the first paper is going to look at the long-term effects of CHIP eligibility expansion on SSI enrollment, and my Mathematica colleague, Mike Levere, will be presenting, and his discussant will be Steve Hill, who I've known longer than anyone else in this room, almost 30 years. We went to grad school together. We both started at, age 10? So take it away.
So thank you very much. I'm going to speak today about the contemporaneous and long-term effects of CHIP eligibility expansions on SSI enrollment. This is joint work with Sean Orzol and Lindsey Leininger at Mathematica and Nancy Early at SSA. And I just particularly wanted to thank Nancy for her instrumental work with the putting together the data that we were able to use for this paper. So there's a current policy debate about the appropriate level of generosity for public health insurance eligibility, where recent legislation considered by Congress would really substantially cut the level of Medicaid eligibility. And there's been a lot of research in economics about how changes in Medicaid eligibility affect health and how they affect labor market outcomes given kind of incentives. And I think it's also really important to think about, well, what are the spillover effects of Medicaid eligibility into other programs, and in particular into disability insurance programs. That may have potentially very large fiscal consequences, given that if you were to, say, reduce Medicaid eligibility, but at the same time that were to increase participation in SSI or SSDI, that may have a significant effect on what those reductions in fiscal savings are. So there is a recent literature on the relationship between health insurance eligibility and SSI and SSDI applications that is mostly focused on the adult program, and I'm going to focus today on children's SSI. And so our main research question is, how do changes in Medicaid eligibility affect participation in children's SSI? And we're going to focus on CHIP-era expansions in Medicaid that happened in the late 1990s and early 2000s, and I'll tell you a bit more about that in 1 minute. And we think that increases in Medicaid eligibility are likely to reduce SSI applications. The reason for this is that in most instances, in most states, when you qualify for SSI, you also automatically receive Medicaid coverage as a result of that SSI award. And so if you have Medicaid coverage from somewhere else, that's going to reduce the potential value of a new SSI award, where if you have a reduction in value, but there are still some costs associated with submitting an application, if not monetary, then certainly in terms of an administrative burden, then a reduced benefit and a constant cost would mean that that net cost benefit analysis could lead some people to reduce their applications into SSI. And to give you a very quick overview of our results, we're going to find that overall there's a very small relationship between Medicaid eligibility and SSI applications, but in particular states where there is not an automatic link between SSI and Medicaid, where in states where there's an additional criteria to get Medicaid eligibility after you get an SSI award, we're going to find that increases in Medicaid eligibility significantly reduce SSI applications. So there's a bit of background on the CHIP era expansions. In the late 1990s, the Children's Health Insurance Program was established in order to expand public health insurance coverage to near poor children, where in order to qualify for Medicaid, you have to have an income below a certain threshold of the federal poverty level. And so for people who had incomes that were too high to qualify for Medicaid, but that their parents' incomes were too low in order to afford private health insurance coverage, the establishment of these CHIP programs helped to cover that gap. Like I said, this happened between 1997 and 2002, and the overall effects varied by a child's age, where the reason for that is that before CHIP was established, the income eligibility limits were higher for younger children, so that more children were covered who were a younger age, and therefore when the programs expanded, older children saw relatively bigger increases in their Medicaid eligibility. So this is supposed to be a two-part graph, and it is not. I would like you to focus first on the black line in the top left graph, just so I can single out and try to explain what this picture is showing. Essentially, what we're trying to show, so if you focus on that black line in the top left graph, is what we're estimating is the percent of children at a given age in a given year in a particular state that are eligible for Medicaid. And so for children who are ages 1 through 5 in Delaware, in 1997, about 35% of them were eligible for Medicaid. And we estimate that using the 1996 CPS, and we used a fixed national cohort where we take everybody throughout the US so that we're not going to be subject to potential changes in people choosing where they live, affecting this estimate. So in 1997, for children ages 1 to 5 in Delaware, the income threshold was 133% of the federal poverty level, and 35% of kids were eligible. That was the same in 1998, and then in 1999, you see this increase to about 50% of kids being eligible when Delaware established a CHIP program that increased the threshold to 200% of the federal poverty level. The rest of the figure shows that there's variation in terms of when Medicaid was expanded and by how much and to which children, given that there's this variation across time and across states and across ages. So you can see that, for example, in Vermont, the expansions in Medicaid happened in 1998. In New Jersey, it happened over a couple of different years. And in North Dakota, there were much smaller expansions at all. And so we're going to use that variation in when Medicaid was expanded and by how much as part of our estimating strategy. So our overall goal is to estimate the impact of increased Medicaid eligibility on children's SSI applications. And we use that variation in state policy as a type of natural experiment for expansions in Medicaid. So this is similar to, this is the simulated eligibility measure that's been used by Curry and Gruber and a lot of other studies. And the key thing is that variation in when and where these expansions take place is entirely due to differences in the state-specific generosity, where because we use that fixed national cohort, it's not that people potentially move to a state where there is higher eligibility for Medicaid, and therefore that's going to affect this estimate. There's not any changes due to the economy evolving over time. All of these differences are due to the state-specific rules. And so essentially what that means is that where and when you are born is going to randomly affect your Medicaid eligibility. And we're going to use that variation in Medicaid eligibility to estimate the impact on SSI applications, where our main outcome measure is going to be the number of children at a particular age in a given year in a given state that applied for SSI, and we get that using the supplemental security record from the SSA administrative data. Our estimating strategy is going to control for any cross-state and cross-year variation using state and year fixed effects. And we're also going to control for a general age trend in SSI applications, because the older that you were up until age 7, the more likely you were to apply for SSI, whereas after age 7, the older that you are, the less likely you are to apply for SSI. So all of our findings are going to be deviations from that general trend. And so these are our main impact estimates on SSI applications, where we find that a 10 percentage point increase in Medicaid eligibility is going to reduce SSI applications by 1/1000th of a percentage point. So that's very small in magnitude, and also relatively, a 10 percentage point increase is about a 20% increase in Medicaid eligibility, given that the average was about 46%. And that 1/1000th of a percentage point corresponds to a 0.02% reduction in SSI applications, because the average SSI applications per capita was about half a percentage point. And that's a very small effect, but it's also fairly precisely estimated, because we can rule out with our confidence interval any increases or decreases of more than 3%. And we also, rather than use state and year fixed effects, we also use state by year fixed effects, and that doesn't really affect our results. And I'll tell you a bit more about some other robustness checks in a minute. So when we started the project, we wanted to look into state heterogeneity, which I alluded to earlier, because there is a different relationship between SSI and Medicaid in different states. So in most states, which are called 1634 states, when you apply for SSI, you're also simultaneously applying for Medicaid. And so if you get an award of SSI, you will automatically receive Medicaid coverage. There are some other states that have an additional criteria to get Medicaid, where in some of those states, you have to just file a separate application that will be accepted with certainty. And in some of the states, there's a stricter income criteria so that you might not actually get Medicaid even if you get SSI. And you can see a list of the states up here. And really importantly, it's not that these are like red states or blue states. They're kind of a random grab bag of states. And so what we initially anticipated was that in the states where you automatically get Medicaid after an SSI award is where we would see the biggest reductions. And the reason that we thought this was that in those states there's a stronger link, so that if you get Medicaid eligibility from elsewhere, that has the biggest reduction in value of a new SSI award. In fact, we find the exact opposite. And what you can see in this table is that in states where there is an additional criteria to get Medicaid after you qualify for SSI is where there's the biggest reductions in SSI applications. So if you have that same 20% increase in Medicaid eligibility, that reduces SSI applications by 12% in these states. Now, these states are definitely different. You can see in the second line here that on average, many fewer people apply in these additional criteria states. Importantly, the acceptance rates are approximately the same across the two types of states. And so what we think may be the case is that the type of person who is still going through the process of applying in the states where there's an additional criteria is the type of person who particularly values that Medicaid award. And so there's the biggest effect for them that there is a reduction in SSI applications after increases in Medicaid. But if people want to talk about this later, I'd be very happy to discuss some other reasons that you think this might be the case. Our estimates are pretty robust. We do a few different specification checks where rather than look at variation coming from state and year, we estimate the variation in a couple of different ways using either age and state or age and year, and we find the same overall result, that there's no overall effect of Medicaid eligibility on SSI applications, and that there is a big reduction in states where there is this additional criteria to qualify for Medicaid. We also vary the base year that we use to calculate the simulated eligibility. I said we use the 1996 CPS. If we use different years, it doesn't affect the estimate. And really importantly, we also use old age applications as a placebo test, where you would think that for people who apply for SSI who are older than 65, their eligibility is entirely determined by income rather than any disability criteria. They also are likely to have Medicare coverage, and so you wouldn't think that changes in children's Medicaid eligibility would affect those old age applications, and they don't. We find no overall effect and none of the same state heterogeneity. So to conclude, we find that overall increases in Medicaid eligibility don't really affect SSI applications, but in particular states where SSI awards did not automatically lead to Medicaid coverage, we find that there is a big reduction in SSI applications from increases in Medicaid eligibility, suggesting that in some states there is some substitution between these programs. Moving forward from here, we have some additional outcomes that we're going to look into for this contemporaneous analysis, which is what I've been talking about. But as you may have seen in the title, we also have a long-term analysis, and that is still fairly preliminary. Our results are somewhat mixed. What we do is we look at the effect of the total years of Medicaid eligibility during childhood and see how that affects long-term SSI applications. That may have a particularly important effect because if people who receive SSI tend to do so for a very long time, and so if there are potential changes in SSI awards and applications from Medicaid eligibility in childhood, those effects would be magnified in the long term. We might think that increases in Medicaid could reduce SSI applications in the long term if increases in Medicaid improve health, but at the same time, it might also increase SSI applications in the long term if you're more likely to see a doctor and have a diagnosis of some type. And so our preliminary results kind of, depending on which specification, it looks positive or negative, and so we're still looking into that, but we will keep you posted. So thank you very much.
Steve's from Agency of Healthcare Quality and Research. So he's sort of qualified to talk about this paper.
About healthcare, right?
Yeah.
So my comments have a disclaimer, and that is exactly as Gina said. They represent my comments, not those of the Agency for Healthcare Research and Quality or the Department of Health and Human Services. And so I really like the data and the methodology in this paper, and I think this is really fun to read. And I just want to review the main findings of the paper. So the effects of Medicaid and of Medicaid and CHIP and public insurance in general, eligibility on SSI applications for children and awards for children. Overall, they found a small but not statistically significant effect. And there was, when they broke it into two groups of states that auto-enrolled kids into SSI and states that required a separate Medicaid application, they found no effect in states that auto-enrolled SSI enrollees in Medicaid. And then for the states that required a separate application, they found a decrease in SSI applications and awards. And one thing about those states that they point out in the paper that didn't get brought up here is that many of the states that have separate applications also had stricter eligibility rules than the SSI program. And so, and the results again are robust to several specification checks. So, let's see. So I have three kinds of comments. The first is I think that it would be helpful to tie the paper more, to explain better how SSI income eligibility criteria relate to CHIP eligibility criteria. Second, I'm going to talk about some of the mechanisms that could increase or decrease SSI enrollment in response to changes in CHIP. And then I'll talk about about some of the factors that affect substitutability between CHIP and SSI. and maybe explain it in a slightly different way than Michael did. So SSI income eligibility determination is probably pretty familiar to this audience, so I won't talk about it, but it's different from CHIP eligibility, in particular that there are some very generous disregards for earned income. For CHIP, the typical state had a net income test, and the net income test had a small disregard for earnings, but there was also a disregard for childcare expenses. And I put together a simple spreadsheet so I could sort of sort this through a little better for myself. And what I found is if there's one disabled child in the family, and the family size in total is 2 to 4 adults, and their earnings are the only source of income, then the child would be eligible if gross parental earnings were less than approximately 185 to 220% of poverty, depending on the family composition. So, and that's because of the generous disregards. So if you account for the CHIP childcare disregards, earning 220% of poverty is really about a net income of 200% of poverty for CHIP. So the SSI threshold is within the range of CHIP, and so that's actually helpful for thinking about this study and thinking about suitability between the programs. So, there are a couple of reasons why CHIP could have increased SSI awards. And the first one is the welcome mat effect. And when states reported that when they went out with their outreach efforts to get kids enrolled in CHIP, they got a lot of kids enrolled in Medicaid as well. There were all these kids who were eligible but not enrolled. And you could have had a similar effect for SSI as well. The Government Accountability Office also put forward a hypothesis that when kids get CHIP, they're going to see their providers are going to screen them and diagnose them, and then the diagnoses could be used for SSI applications. And that's kind of a dynamic model. Where's Dave now? But in fact, since there wasn't any evidence of an increase, I think we can move on from there. So the paper really focuses on this substitution between the programs, and I think, explain it a little differently, or how I see it a little differently. And so enrolling in CHIP is easier than enrolling in SSI. So families go for the less burdensome approach, and CHIP applications were definitely simpler. SSI requires a disability determination. It requires complicated income and asset counting rules. And if you don't get there through on the first try, there can be a lengthy appeals process. But the big thing missing from this story, I think, is SSI's cash benefits. So for whom is getting CHIP's insurance coverage equivalent to getting Medicaid plus cash benefits? Well, it would have to be people who were eligible for only small cash benefits, I think. So these would be people with maybe incomes between 200 and 220% of poverty. So maybe this isn't a big population. Maybe if you think about people who have a lot of fluctuations in their income, SSI would get really complicated, and so the families would be better off on CHIP. And I think it's an interesting question how many families would be in that situation. But anyway, so also the program substitution of hypothesis, families with incomes above 220% of poverty, gross income, they really wouldn't have capacity to substitute between programs because they really aren't eligible. So a sensitivity test for the kind of results we've seen is there an impact of eligibility increases above that limit in CHIP and on applications and awards for SSI. So the paper focuses on one feature of that states that could affect the substitutability between the programs. Again, that's separate applications, and that's correlated with states that have stricter income eligibility rules. But another factor is that some states, including some of the 209B states with stricter eligibility rules, had pathways of eligibility for people with disabilities that had higher income thresholds. So maybe they didn't need to go to CHIP. These pathways do require the disability determination, so they do, it's not a perfect substitution with CHIP, but they could also be as important as having a separate Medicaid application. States were giving Medicaid to people who receive state-financed supplemental disability payments. 4 of the 209B states were doing that. During the time period of the study, a growing number of states were using poverty-related eligibility pathways for people with disabilities. Hawaii is a 209B state, and it also covered people with disabilities up to 100% of the federal poverty line. Now, an important thing about this is it doesn't sound so great, but actually that's a net income threshold. And so all those SSI disregards apply. So a family, again, it's the same spreadsheet I was using before, they could have gross incomes of around 240 to 310% of poverty. So that really does put you makes CHIP a little less relevant for people in those states. So the paper focuses on variation in CHIP income eligibility through their eligibility rate, but there are other factors related to CHIP that could affect eligibility. There's a lot of research on premiums in CHIP and how that can be a barrier to take up, and there might be other factors like asset tests. And I really like the methods used in this paper. Michael spent some time talking about the Curry-Gruber approach, and I think that could possibly work for thinking about income eligibility thresholds for the disability pathways, if you just focus solely on the income rules and not thinking about the disability issues, disability determination. But I think it's going to be difficult to account for policy endogeneity if you're looking at CHIP premiums and assets, but I think it would still be worthwhile. And the paper used 2 separate regressions when looking at types of states. And I think, so that's basically an interaction effect. And I think it would be useful to look at just entering these policy variables directly and do they have any effect on the substitution or the application rates on their own? And I think that would be useful for policymakers. So in summary, overall, the small and statistically insignificant effect is consistent with the competing mechanisms for increasing and decreasing applications, and for the small population that's likely to have maybe small cash benefits. I think there are a lot of studies about geographic variation, and I think that the additional features related to the substitutability between SSI, Medicaid, and CHIP could be important to take those into account rather than just looking at the one. And I think this study is going to help policymakers understand the complex relationships between health insurance and disability benefits, especially in a time period where CHIP is up for reauthorization and Congress needs to decide what to do. Thank you.
All right, next up is Priyanka Anand from Mathematica, soon to be at George Mason University. She's leaving us, but we'll still talk to her. She's going to talk about long-term outcomes for transition-age youth with mental health conditions who receive post-secondary education support. That's a mouthful, but you'll understand what she's talking about soon. And her discussant is Manasi Deshpande from University of Chicago.
Well, thank you all for being here. As Gina mentioned, today I'm going to be talking about long-term outcomes for transition-age youth with mental health conditions who receive post-secondary education support. And this is joint with Todd Honeycutt from Mathematica. So state vocational rehabilitation agencies, or VR agencies, help people with disabilities achieve their employment goals. And they do this by providing a wide variety of services. These include paying for assistive technology, job placement services, and counseling services. One service in particular that we are interested in this paper is providing support for post-secondary education. So this would be providing tuition assistance, paying for books or other supplies to attend college or vocational training. And we're interested in support for post-secondary education because it's thought that it may improve employment outcomes. It's also a goal of many people with disabilities who apply for VR support. We're also interested in youth with mental health conditions for a couple of reasons. The VR population, youth with mental health conditions comprise a large portion of the VR population, and they tend to have lower employment outcomes. And finally, past work has shown that youth with mental health conditions are less likely to receive VR services in general, and in particular, they are less likely to receive college supports than youth with other types of disabilities. So for this reason, the objective of this paper is to examine the relationship between receiving VR support for post-secondary education and long-term outcomes for youth with mental health conditions. We go about this by answering two main research questions. The first research question is, how do long-term employment and earnings outcomes vary by receipt of post-secondary education support for transition-age youth with mental health conditions? In the paper, we also compare this to this question for youth without mental health conditions, but given time constraints, I'm just going to focus on youth with mental health conditions here. Our second research question is the same as the first, but instead of looking at employment and earnings outcomes, we look at the receipt of federal disability benefits as an outcome. So this would be receipt of SSI or SSDI. The past literature on this topic tends to focus on people with all types of disabilities and not just focus on those with mental health conditions. But even among this literature, the results are mixed. Some of the papers find that receiving post-secondary education services has no effect on employment upon VR exit. Others find that there's actually a slight decrease in employment upon VR exit. The paper that does look at people with mental health conditions was by Dean and his co-authors, and they found that there was a decrease in employment 2 years after receiving VR services, but they only looked at one state, which was Virginia. So in our paper, we make a couple of contributions to this literature. First, we do focus on youth with mental health conditions. We also examine outcomes 9 years after VR application. So most of the literature, as I mentioned, looks at outcomes upon VR exit or 2 years afterwards, but we're able to examine a much longer time period of 9 years after VR application. We also look at 3 types of employment outcomes. We look at employment, we look at earnings, and we look at receipt of federal disability benefits, so SSI or DI. And finally, we are able to control for individual characteristics and state characteristics in our analysis. Sorry. So, is this gonna? I think I'm pushing too many buttons. No, that went backwards. Oh, okay. All right, this is the slide. So we use 3 data sets in our analysis. The first data set we use is the RSA 911. And this is an administrative data set that provides us with information about the VR services that are received. And we use this data from 2002 to 2013. We then merge this data with the 2013 disability analysis file, the DAF, and the DAF provides us with information on the federal disability benefits that are received by our population for all years from 2002 to 2013. And then finally, we merged the RSA 911 and the DAF with the master earnings file, which provides us with earnings information, and this is also administrative data. Our final sample size is approximately 437,000 VR applicants. Our sample consists of first-time VR applicants who submitted their application from 2002 to 2004. And because we have data that goes through 2013, we're able to follow each of these 3 cohorts for 9 years each. Our sample is limited to those who are ages 16 to 24 at application, so these are the transition age youth, and we just look at those that are eligible for VR services. There are 2 main components of our empirical methods. So the first thing we do is we provide descriptive statistics of our main outcomes by service receipt. So we look at the outcomes for those who receive support for post-secondary education and compare it to those who receive support for other services but not post-secondary education. We then want to see if the relationships we observe in our descriptive statistics hold after controlling for individual and state factors. And so we estimate a regression between the main outcomes of interest on VR service receipt while controlling for these other characteristics. I seem to be having more trouble with this than most. Okay. So here are the employment rates for youth with mental health conditions who receive services other than post-secondary education support. And we show the employment rates for each of the 9 years, 1 year before application and the 9 years after VR application. And you can see that in the 9th year after VR application, about 45% of youth with mental health conditions who receive services other than post-secondary education support are employed. And we now compare this to the employment rates of those who do receive post-secondary education support. So the blue line on top, the dashed blue line, are those who receive college support, and the green dotted line are those who receive vocational training. And you can see that those who receive post-secondary education support have higher employment rates in every year than those who receive other types of support. But this includes the year before application, which suggests that there is a strong selection into those, among those who receive post-secondary education services. Nonetheless, we do see that the gap in the employment rates between those who receive post-secondary education support and those who do not does get wider over time. Next, we look at the average annual earnings of youth with mental health conditions, and we start with those who are receiving services other than post-secondary education support and compare it to those who do receive post-secondary education support. So again, it's even more clear here that the gap in earnings between those who do and do not receive post-secondary education support is really growing over time, especially for those who receive college support, which is the dashed blue line on top. As I mentioned, we want to make sure that we want to check to see if these relationships still hold after we control for individual and state characteristics. So here we show the results from 2 sets of regressions. The 2 bars on the left show the results when the outcome is whether the individual was employed in the 9th year after VR application. And the 2 bars on the right side show when the outcome is the log earnings in the 9th year after VR application. And the blue lines show the coefficient on receiving college supports. So the estimate is the difference in the outcome from receiving college support versus not receiving college support after controlling for individual and state characteristics. And the green lines show the same for receiving vocational training. So here we can see that the regression estimates confirm what we saw in the descriptive analysis, which is that youth with mental health conditions who are receiving post-secondary education support, that they tend to have higher earnings and they are more likely to be employed in the 9th year after VR application than those who do not receive those supports. Next. I know. Should I be pointing it at something? Or, okay. Next, we look at the receipt of federal disability benefits. For these analysis, we split our sample into two groups. We look at those who were receiving benefits at the time of VR application and look to see whether they had those benefits foregone in the subsequent 9 years. And then we look at those who were not receiving benefits at the time of application and look to see if they started to receive them in the following 9 years. So I'm going to start with the results for youth with mental health conditions who were not receiving benefits at the time of VR application. In the first row, you can see that those who received college support a smaller percentage of them received federal disability benefits in the subsequent 9 years than those who did not receive college support. And the same is seen for vocational training. So about 12 to 13% of those who receive post-secondary education support subsequently receive benefits compared to 19% of those who did not receive any type of post-secondary education services. However, among those who did receive benefits in the following 9 years, the number of years they received benefits for was fairly similar between those who did and did not receive post-secondary education services. Once again, we check to see whether these relationships still hold after controlling for individual and state characteristics. On the left side, the outcome variable we're looking at is whether the individual received SSA benefits anytime during the 9 years after VR application. And on the right-hand side, it's we look at the number of years of benefit receipt, conditional on receiving benefits. And just like we saw in the descriptive analysis, we can see that those who receive post-secondary education services are less likely to receive federal disability benefits in the subsequent 9 years than those who did not receive post-secondary education services. We also see a slight decrease in the number of years of benefits for those who receive post-secondary education services, but these numbers are quite small and they are not always statistically significant. And our last group that we look at is youth with mental health conditions who were receiving federal disability benefits at application, and we look to see whether those benefits were suspended at any time or over the next 9 years. And we can see that the percent of youth that had their benefits suspended were fairly similar between those who did and did not receive post-secondary education services. However, among those that did have their benefits foregone for work, we see that those who received college support or vocational training had a much larger amount of benefits foregone for work than those who received other types of services. Again, when we look at, when we conduct our regression analysis, we find very similar findings. We find that those who received post-secondary education support had a much larger amount of benefits foregone for work than those who received other types of services. So to summarize, we found that for youth with mental health conditions, receiving post-secondary education support was associated with a higher likelihood of being employed and higher earnings in the 9th year after VR application. And we found that for those who were not receiving benefits, federal disability benefits at the time of application, that there was a lower likelihood of receiving benefits in the subsequent 9 years. And among those who were receiving benefits at the time of application, we found that there was a larger amount of benefits foregone for work for those who received post-secondary education services. So I want to emphasize that the relationships we found here are not causal. They're merely intended to set a baseline for the relationship between post-secondary education support and outcomes. And we found that based on our descriptive analysis and our regression analysis that there does appear to be a positive relationship between post-secondary education and outcomes. However, in order to determine whether this is a causal relationship, it's important to conduct a rigorous evaluation, possibly through a demonstration with some form of randomization. Another thing that will be important to determine besides causality is really thinking about the costs and benefits of providing this type of support. So past research that we've done has shown that providing support for post-secondary education is actually quite expensive relative to other services. The cost is estimated to be about $2,600 to $7,000 higher compared to other youth with mental health conditions who receive other types of support. However, as we showed in this project, that the benefits foregone for work is along the similar amount, about $2,100 to $5,000 higher for those who receive post-secondary education. And this doesn't include all the other benefits from working, for example, the income that they earned. So when thinking about next steps in looking at VR support for post-secondary education, it's really important to determine causality through rigorous evaluations and also consider these costs and benefits. So thank you very much.
Thanks very much. Can you hear me? Yeah. I'm Manasi Deshpande from the University of Chicago and NBER. Thanks very much for inviting me to discuss this paper. So first, I want to start just by providing some context for this paper and the broader research and policy context, and then I'll talk specifically about the paper and then tie it back to some of these bigger questions. So as Priyanka said, the VR program provides services to individuals with disabilities to promote employment. In 2016, the federal government spent $3.1 billion in federal grants to state agencies to implement the VR program. And services include counseling, training, referrals, transportation, and post-secondary education support. Now, the 2014, the new WIOA requires VR agencies to spend at least 15% of that federal funding on youth services. And there are probably people in the room who know more about this than I do, but at least in my work with VR agencies in the past few years, this appears to be a binding constraint for most of these agencies. So most of these agencies are doing a lot of work to increase their pre-employment transition services for youth with disabilities to be able to meet this 15% requirement. So the sort of broader research and policy context here, I think, there are two major questions with respect to VR and youth right now. The first is, how cost-effective is VR in improving outcomes for youth with disabilities? And the second is, how do we connect more youth to VR services? So I feel obligated as a researcher to say that ideally we would know the answer to the first question before working on the second question. But if we only funded or did things for which we had evidence, there would be probably 3 government programs in the United States. So with respect to the first question of how cost-effective is VR, this is something where we don't really have, to my knowledge, any causal experimental evidence on this question. And I think it's an incredibly important question given how much money we spend on VR. The PROMISE program, the Promoting the Readiness of Minors in SSI, will be evaluating a bundle of services for SSI youth that includes voc rehab, but also includes a lot of other services. So I think that's kind of the sort of most promising evaluation right now to get a sense of how effective VR is. On the second question of how to connect more youth to VR services, so SSA doesn't provide VR referrals to SSI youth, and there's a recent GAO report that found that schools are supposed to be the primary connection between these youth and voc rehab agencies, but schools are often doing a poor job. And in other work with my co-author Rebecca Dison-Ross, we've conducted a lot of focus groups of SSI youth and their families, and specifically what do they know about the voc rehab program. And we found it's somewhat heterogeneous across states, but in a lot of states that these families don't seem to be aware that VR services are even available. When you tell them what services are available through their VR, they express strong preferences about what they think would be appropriate for their child and what services probably wouldn't help their child. And so it does seem like there is a lot of capacity to provide more information about voc rehab to these families. So with respect to the with Priyanka and Todd's paper, so just to provide an overview, the main question is, how do employment, earnings, and disability receipt vary by receipt of college supports and by mental health conditions? And they're using VR administrative data linked to SSA earnings and disability receipt data. And I think the administrative data linkage here is a big contribution. It allows them to look at long-term outcomes. It allows them to look at employment and disability receipt 9 years after the VR application. So their main findings are that youth who receive college supports are more likely to be employed and less likely to receive disability benefits 9 years later than youth who receive other types of VR services. And that these differences are larger for youth with mental health conditions than youth without mental health conditions. So Priyanka emphasized in her presentation mental health conditions, but in the paper they also have results for other youth. So what we learn from this paper, I think, so first is, as I said, I think it's a very important topic, and especially the linked administrative data lets us look at long-term outcomes. And so their descriptive results allow us to compare long-term outcomes across groups. So in particular, what they find is that employment rates 9 years after VR applications, employment rates are about 50% for those who apply for VR among those with mental health conditions. They're much higher for youth who applied for VR and received college supports. And then for youth who received other VR services, employment rates are similar to the rates for those who just applied for VR. And then for non-mental health conditions, you can see that overall employment rates are higher and the patterns are similar. So as the authors say, and I think it's important to reiterate that these results are not causal. So the differences in these groups in the graph that I just showed reflect a lot of different things. So they reflect selection into college. They reflect the treatment effect of college itself. They reflect selection into college supports. And then they reflect the treatment effect of the college supports. So treatment effect of the college supports is I think, really what we want to know in this paper, ideally. But we're also going to get a lot of other factors that account for these differences. And this is a context in which selection is probably very important, right? That youth who apply for and receive college supports probably did so because they were planning to go to college, right? They are selecting into college, and then they're also, because they went to college, many of them went to college, they will also have higher earnings and employment rates for that reason. And as Priyanka mentioned, you can sort of get at this by looking at the difference in the year of VR application or just before VR application, and you can see that employment rates are higher for those who are already higher for those who are applying for college supports. Even that is likely to understate the amount of selection, right? Because the youth who apply for college supports might already be in school full time, and so they might not be employed because they're in school. And so even that sort of methodology of using the pre-application difference in employment rates is probably going to understate the amount of selection. So in terms of interpretation, two thoughts. One is it would be helpful to know more about what the comparison treatment is. So the authors are comparing college supports to other VR services, and the main reason they give for this, which makes sense, is that they want to avoid picking up selection into VR. So people who apply for VR and people who don't apply for VR are different in various ways, and so they're just focusing on the group of people who apply for VR and then comparing within that group people who receive college supports versus people who receive other types of services. But probably, ultimately what we want to know is what is the effect of college supports versus no VR services. And one way to get at that might be to do some kind of matching between the youth who receive college supports and youth who don't apply for VR. And I realize that in administrative data that's difficult because you just have so such limited covariates. And another question is, what is the comparison group? So I'd like to know more in particular about this non-mental health condition group. So my sense is that it combines youth who have non-mental health disabilities for whom we might expect similar outcomes or worse outcomes than the youth with mental health conditions, but also youth with no disabilities or less severe disabilities for whom we might expect better outcomes. And if the non-mental health comparison is combining those two groups, it's a little bit hard to know how do I compare the mental health group with the non-mental health group. So that some clarification on composition and characteristics would be helpful. Okay, and then just returning to those two questions from the first slide, how cost-effective is VR in improving outcomes for youth with disabilities? Reiterate what Priyanka said, that there is a need for causal evidence in this area, especially given how much we spend on VR, and especially given these new WIOA requirements to spend more on these services for youth. And I think that the new WIOA requirements provide an opportunity for federal and state agencies to evaluate youth VR services. So as I said, a lot of these agencies are ramping up or investing in their pre-employment transition services, and they are really interested in what works and what doesn't work. And I think there is an appetite for evaluating some of these services for youth to understand what works. And then with respect to the second question of how to connect more youth to VR services, we know that it seems to be that families have pretty limited information about the availability and quality of VR services. The recent GAO report recommends that SSA explore options for increasing connections between these SSI youth and NBER agencies and services. So, thank you.
All right, last up on our panel is Seth Seabury from the University of Southern California, and he's going to talk about the impact of Medicare Part D on expenditures and utilization of Social Security disability insurance beneficiaries. And his discussant is Gal Wettstein from the Retirement Research Center at Boston College. And you guys, red light means stop. Green light means go.
Set up an electric shock. Well, thank you. It's great to be here. This is joint work with Amitabh Chandra from Harvard and Ning Fu, a postdoc at USC with me. And this is very much research in progress, so I'm looking forward to getting your input and sharing it with you, and also getting your thoughts on other directions we can take it. So the goal of this research is to look at how the introduction of Medicare Part D affected people on SSDI, really looking at under 65 Medicare beneficiaries specifically. So in 2006, as probably almost everyone here knows, Part D offered prescription drug coverage through Medicare to beneficiaries for the first time. And this included people who were eligible based on being over 65, as well as people eligible through their disability status on SSDI. And so there's reason to believe that extending prescription drug coverage or improving prescription drug coverage for people with chronic health conditions, disability, could have a very big impact, bigger than, say, even the general population. Just by the nature of their disability, they often have greater health needs. Prescription drugs can potentially play a big role in managing their health conditions. And also, these are individuals who generally, or families with relatively low income, for whom out-of-pocket spending on drugs could prove a bigger financial burden. So we might expect whatever effects that we think Part D had on the Medicare population more generally, we might expect those effects to be even bigger in the under 65 disabled population. However, any sort of worthwhile endeavor, it's always a little more complicated than a sort of simple story, right? And part of the problem here that quickly became apparent to us as we started working on this area is that the nature of the individuals' disabilities expanded their eligibility for other types of programs, even prior to Part D. So in particular, this Medicaid dual eligibility is what we're focusing on mostly here. But this was something that it became apparent to us was a big deal that we needed to consider. Medicaid typically offers prescription drug coverage and they did so prior to Part D. But that drug coverage varies a lot across states in terms of the generosity and what's covered and how much they'll pay for. And so there's a potential confounding variation that we're not going to observe very well amongst people with dual eligibility. And then there's also this issue that dual eligible beneficiaries were switched automatically onto Part D, so that there's this, it's not just that there's potential heterogeneity, there was a change around 2006. So we want to be careful thinking about other program status when trying to estimate this. Now, this is Part D was obviously one of the biggest social insurance changes in many, many years, especially prior to the ACA. And so it generated a lot of work amongst economists and health policy scholars. But it's most of that work is focused on aged beneficiaries, people over 65. And just give a very quick, high-level summary of some of the existing findings related to what we're doing here. Part D was associated with what I'd call a modest uptick in drug spending and utilization for over 65 beneficiaries. Part of the reason I call it modest is that there appeared to be a lot of crowd out of private drug insurance. So, but there was a large reduction in out-of-pocket spending for the over 65 beneficiaries. And the studies I've seen at least had relatively little to no impact on health outcomes or healthcare utilization. So what we think is that there was some increase in spending, some increase in utilization, not an obvious impact on health. But there really hasn't been a great deal of study of this in SSDI beneficiaries. So what we're doing is that we're looking at the impact. So we're going to be looking at the introduction of Part D in 2006 and how it affected prescription drug spending, the number of prescription fills for the under 65 Medicare population. We're also going to look at hospitalizations as kind of a key outcome, and also look at out-of-pocket spending. As some secondary outcomes we're going to look at include self-reported health, receipt of samples, free samples, type of pharmacy used, and office-based provider visits. Talk about how to interpret those in light of our primary outcomes in a bit. And then the second part of the study where we want to get to, I'm not going to talk about a lot today because that's we still have much more to do on that. But because we're going to be basically doing a difference in difference analysis, we're certainly worried about potential changes in the beneficiary pool associated, and in particular whether the availability of prescription drug coverage changed who is applying to SSDI. And we've done a little bit we're very early stages of work on that. We're not finding obvious compositional changes, but there's much more to do. So I'm not going to talk a lot about that today, not because it's not important or we're not concerned, but it's just definitely we're still working on that. So the data that we're using come from the Medical Expenditure Panel Survey. We're using a framework, a setup very similar to the Engelhardt and Gruber paper on Part D from 2011. We're combining data from the full year consolidated and the prescribed medicine files. We're focusing on 2001 to 2009. So we stopped at 2009 in our data, partly because of the ACA and all the or primarily we stopped in 2009 because we wanted to stop pre-ACA and all the potential changes that could have been introduced from that. But also actually in light of Kathleen and Nicole's study, it's actually helpful for us to have stopped there, happy accident, I guess, because we weren't thinking about this, but there could have been a lot of compositional changes from the Great Recession, and the 2-year waiting period for SSDI to get on Medicare helps us avoid those problems up to 2009. And so we're focusing on individuals 18 plus with 12 months of Medicare coverage. So we're looking at people covered in Medicare for the full year. We're going to stratify based on over and under 65. So that I want to be clear, I'm calling them SSDI beneficiaries. There are some under 65 Medicare who will not be on SSDI. They could qualify through end-stage renal disease or ALS, but the majority will be under 60. Will be on SSDI. And we're also taking kind of a loose definition of dual eligibility. There are very different levels of Medicaid eligibility. It's going to vary by state. In a lot of ways we can't handle in the MEPS. So we're taking just kind of a very expansive definition, and we're saying if you have at least 1 month of Medicaid coverage in the sample, then we're going to sort of call you different than the people who are 12 months with no Medicaid. So that's how we're breaking dual eligibility. And then we're also going to look at individuals 18 to 64 with 12 months of private insurance coverage. So you can think of 4 distinct groups that we're interested in. We have the under 65, Medicare only, under 65 with also Medicaid, over 65, Medicare only. We're simplifying and excluding the over 65 duals, and under 65 privately insured. So 4 different groups of people based on their insurance coverage. And the point is we're taking them and we're using those different groups in 2 sets of difference and difference regressions based on comparing under 65 beneficiaries to, as the treated group to controls pre and post 2006. So you can think of we're doing regressions where we're comparing under 65 Medicare to privately insured, and in that we're thinking of it as a treated group compared to an untreated group. Then we're also going to look at under 65 Medicare to over 65 Medicare, 2 treated groups, but in sort of more of a dose-response type of model. We're curious as to whether the impact of introducing Part D had a bigger effect on the under 65 Medicare population compared to over 65. And the other covariates include standard demographics, age, sex, race, education. We're also looking at income and other chronic comorbidities that are reported in the MEPS, so self-reports for ever being diagnosed with heart disease, stroke, emphysema, diabetes, or asthma. This is trying to control for possible changes in the underlying health of beneficiaries. And we're also using MEPS sample weights, and for any regressions, we exclude 2006 as a transitional year, and we're looking at 2001 to 2005 compared to 2007 through 2009. A few figures here, just to show. Basically, it's probably hard to distinguish some of these, but the top 2 lines here represent prescription spending in the year for the under 65. The red represent those with Medicaid, the blue represent those without. And you can see whereas the next down represents the over 65 Medicare, and the lowest spending, as we expect, are the under 65 private. And most of the level differences here are due to differences in underlying health driving spending. And you can see there's really no change post-2006 in spending for the under 65 private. Given the scale, it's a little hard to tell, but there is a bump in the over 65 Medicare. And while there's definitely a pre-trend that we need to be concerned about, seems to be a trend break around 2065 for the under 65 Medicare. Now, if we look at what's interesting is we see what we think is an increase in spending for the under 65 Medicare, but we don't see a change in the number of prescriptions. So these are the average number of fills in the year for the same insurance groups. And what you see basically is, again, private very flat. There's a slight uptick in fills for the over 65 Medicare. But for the under 65 Medicare, we basically see no evidence of any trend. Now, it's a little more variable, so it could be that there's an increase that we're not able to capture. But we're seeing an increase in spending, but no evidence of increased utilization. Now, finally, when I look at hospitalizations, we'd see a pretty clear decline for the under 65 Medicare, but not for either of the other 2 groups. So hospitalizations for private are completely flat. It's a little noisier for over 65 Medicare, but there's no obvious decline. But for both under 65 Medicare only and under 65, what I'm calling dual, you see a drop in the percent of people with a hospitalization in the year in post-2006. So I'll talk about what I think that means in just a second, just to show you the regression findings, what are the magnitudes we're talking about here. If we look at spending versus privately insured in the top panel, there are 2 rows in each panel. The top row is the difference, the bottom row is the difference in difference. You can see that Part D was associated with a $944 increase in prescription drug spending for the under 65. It's actually higher for the dual eligibles, although in percent terms it's pretty similar between the Medicare only and the dual eligibles. So we definitely see an uptick in prescription drug spending, as we saw in the figure. And if we compare the under 65 to over 65 Medicare, you also see an increase, about half as large. So you see definitely a larger increase amongst the under 65 compared to over 65 in terms of the higher spending. Now, also, though, as we saw in the figure, there's no evidence of any increased utilization. And if anything, compared to the over 65, you see a decline in utilization. These are large standard errors. We can't rule out somewhat of an increase, but we're certainly not finding any evidence of it. So on the surface, this is potentially problematic, right? We're expanding drug coverage to a group because we'd like to see them get more access to medications. And so if you see higher spending, but no increase of higher utilization, then it's hard to see whether you're actually getting a real increase in access. So unless you think that they're getting better drugs, this would just seem like you're driving up costs with not necessarily any clear benefit. Now, we do see a drop in hospitalization, so you might wonder, are you seeing a health benefit from that? You know, as I'm used to working with claims data, we often use claims as a measure of health, as a proxy for health. But in reality, hospitalizations reflect both health as well as patient preferences and provider preferences. So one of the hypotheses, it's somewhat speculative, we've got some supporting evidence, is that we think people are maybe going to the hospital less to get medication. Going to the hospital, using the hospital pharmacy might have been a way that people with poor drug coverage were actually getting access to their medications. So we think more than a clear improvement in health, it might be a behavioral change that is resulting. Now, this might still be good. You're saving money by keeping people out of the hospital. But I'm reluctant to claim it's a big improvement in health, particularly given that we're not seeing an improvement in actual drug utilization. One thing we are seeing, however, is a clear financial benefit to the SSDI beneficiaries in terms of lower out-of-pocket spending. So we find, now this is conditional on having at least one prescription fill, but the annual out-of-pocket spending for the Medicare-only group fell by $1,000. So they're spending $1,000 less out-of-pocket on drugs. That's like giving them essentially 7% of their family income. So it's actually a pretty big financial benefit from the introduction of drug coverage. This is about to blow up on me, so I've definitely gone too long. We find some evidence supporting our idea that we think that there's change in provider behavior. We also did see some improvement in self-reported health, but whether it's actual physical health or just sort of perceived well-being, I think is an open question. Probably raised more questions than answers with this work so far. We think it's interesting findings, but there's definitely more that we need to do to understand.
Okay, so hello, and thank you to the organizers and the authors for giving me the opportunity to give some comments on this work. I won't spend too much time summarizing because you just heard it, but basically the paper looks at the utilization of prescription drugs and other health services by those on SSDI and how that changed with Part D. They used two control groups. One is those under 65 who are privately insured as a control group to estimate the total effect of Part D, and the other is those who were over 65 and on what I'm going to call traditional Medicare to estimate the differential effect for those on SSDI relative to the more elderly population. And their findings were, as we just heard, an increase in prescription drug expenditures for those on SSDI, both those who were newly insured and those who were, as the authors call them, dual eligible. There was a decline in hospitalization and a slight increase in self-reported health, but no change in fills. And so most of my comments are going to focus on some ideas on what might be going on. Methodologically, I don't really have any comments that the authors didn't already raise, except that when it comes to the differences between the dual and newly eligibles, I think it's correct, as Seth said, that it's hard to differentiate completely between these two groups, and so any such differences might be understated. So why could there be an increase in expenditures without more fills? One possibility the authors raise in the paper is that it could result from increased brand name drug use as opposed to generics. This would be consistent with the fact that they see an increase in observed expenditure for the dual eligibles because even though those duals already had presumably prescription drug coverage through various state Medicaid programs, those often had restrictions on the generic drugs that could be gotten through that insurance. So an increase could be due to this. Well, another possibility that I thought of, given the improvements in hospitalization and self-reported health, although, as Seth said, there's some different interpretations of those results as well, there could be a switch to using drugs that cure conditions rather than just treating symptoms. And the example I had in mind is the new hepatitis C drugs that sort of came on the market. Clearly, the increased use of that drug is not due to Part D, it's because the drug was developed. But other such similar stories could have been going on, and that could lead to improved health in cases where people get are less price sensitive to these more expensive drugs, like if they get more drug insurance. And then similarly, but not exactly the same, because of the decline in fills, even though it wasn't statistically significant, one thing that stood out to me is that it could be people are using more combination drugs when they get more drug insurance. Often these combinations of drugs are marketed when the component drugs patents are about to expire, and so they would remain generic they would remain brand name once, even past the time when the component drugs were already generically available. And so if Part D increases these combination drug usage, it could be a useful tool to study how effective these are relative to their costs. This is a hot policy topic. There's a decreased pill burden, perhaps better usage of prescribed drugs, but on the other hand, the price is higher because there's less competition. Let me wrap up with just a couple of further potential questions. The study finds larger effects on utilization and mostly on health for the SSDI population than previous literature has in the general population. I think that raises questions, as Seth said. Perhaps when we want to look at the impacts of Part D, it would be useful to look at more heterogeneity in those impacts by health status and income, which are obviously correlated with SSDI status. And the similar effects for dual and newly eligibles is interesting, and I think raises interesting questions on not just whether people are insured, but on the quality of that insurance, what kind of products are covered, and how generous the cost sharing is. So those are my comments for now. And,
Thank you. All right, we got about 10 minutes for questions. Anyone have any? All right, microphone girls.
Hi, good afternoon. I'm just a little bit of background. I'm here today because I have a smartphone app that changes the way companies source, hire, and train people with disabilities. And so my question is for the second one is we have found, because we have this big data set that we don't know how to analyze, so if anybody wants to use our big data set that we don't analyze very well, we found that it's actually more connected to somebody's network. So the idea that it's a lot easier to get a job if you know someone. And so when we, in our mediocre basic understanding of statistics, analyze people that come with a college education that sign up for our platform versus somebody that didn't attend college, they actually don't, that doesn't really change things, more so the network does. And so are there ways for you to accommodate or consider the network effect that happens when people are going through, or is that something that's in anybody's research?
So that would not be something we could do with the data that we have now, but I think it's a great point that there are many benefits to receiving a post-secondary education, and I think the network effects through going to college is one of them. Yeah, the administrative data we have wouldn't tell us exactly, who are the networks that they're coming across while they are receiving their education. But I imagine that there are other ways that, not through our data, but there are other ways that we could look into this really important question, because I think it's a great point that part of the advantage of getting this education is the network you come across. So I think it's a great point.
My name is Sharon. I'm for the first speaker. What is the proposed legislation for the CHIP program? I have a nephew who's on the CHIP program because he's a juvenile diabetic. So what are the proposed legislation? Would it be lessening? And if they had to lose that, would they be able to roll over to a Medicaid program, or what could they do?
I might refer you to Stephen, who might know more about that. I know more of the disability side than the CHIP side.
So I'm not sure what legislation is currently on the table, but what is happening is that CHIP is only authorized for spending through, I think, the end of the fiscal year, but states can continue to keep the money that they have and spend it, and then I think, depending on the state, they'll run out of money. So it's a question of reauthorizing the same program, changing it. The Medicaid Payment and Access Commission has been looking at some ideals of what could be going, what would be solutions to coverage for kids, but generally speaking, it's not clear what's on the table.
Okay, Manasi?
Thanks. I had a question for Mike, actually. Great paper. I was wondering what you know about the effect of these Medicaid and CHIP expansions on just any health insurance coverage for these potential SSI kids. So I think in the general child population, we know that the increase in public insurance coverage is much larger than the increase in having any health insurance, because a lot of kids are going from private health insurance to these public programs when they're expanded. And so a lot of that effect is just an income effect of putting the kid on public insurance instead of private insurance. And so is that also true for the SSI child population, and how should we think about the income effect versus the gain in health insurance?
I'm not sure that I have a great answer. We haven't looked that much into how much, kind of like the first stage of how much health insurance changes as a result of the estimated changes in eligibility. And kind of speaking to the income effect as well.
Is that something that you can do in your look at any health insurance coverage in survey data or something like that?
So we can look at that we have some control variables in our regression from the CPS where everything is aggregated to the population level. So we could look at how the changes in simulated eligibility affect the likelihood of having any health insurance coverage to get at, is it people who are newly qualifying for coverage versus people who are, just changing where that source of coverage comes from. So that's something that I think that we can look into, and we will. Thanks.
Did I see Gil's hand up there? Go.
Hi, so Gilbert Gim from George Mason University. This is a question for Seth Seabury with a third paper. Have you considered looking at Medicare Part D's 6 protected classes of medications to help explain your findings? In essence, when Part D was authorized under the MMA, 6 medications that fall under HIV, mental illness, epilepsy, cancer, and I think organ transplantation were prohibited from being excluded from any formularies that private insurers develop through Part D contracts. And given that you appear to have an expenditure increase, but no change in utilization, you could argue that it's largely price that's driving your result. If a state has Medicaid prescription coverage that's pretty crappy for adults with disabilities, moving to Medicare Part D would significantly increase the number of antidepressants and antipsychotic medications available because they cannot be excluded based on price. So I guess the question, two-part question. One, have you considered that? And then two is, in the MEPS data, do you have the ability to identify people with mental illness, cancer, or some of these categories that could help you to tease out this effect?
Yeah, that's a great point. I think that the answer is yes. One of the things that we want to take, one of the directions we want to take this is to look at the actual types of medications that people are spending and whether that changes pre and post. Hadn't specifically thought of the protected class, but I think that's a great suggestion. We'll definitely want to look into that. And in terms of mental illness, one thing that the MEPS introduced in 2004 was the K6 screening tool. And so we actually looked at that to see whether there's any change pre or post and trying to see if there's any compositional changes. But we could also try to look at, see with, with evidence of psychological distress and see if there was any kind of heterogeneous effects in that population. That would be one way to try to get at that issue. So I think it's a great suggestion.
All right, we have time for one more. I haven't done this side of the room. Okay.
Hi, my name is James Smith from Vermont VR Agency, and it's a question for the second presenters. Well, first, I just appreciate the you're looking at long-term outcome data for VR services. That's really needed. And I also appreciate you pointing out that it's not necessarily a causal relationship. One thing I just ask you to consider is one of the things we observe in Vermont is that we definitely have young folks who come to us where the VR intervention is critical in terms of supporting them go to college. And then there are definitely another group of young people where it's a supplemental support, but they would have, no matter whether VR existed or went away tomorrow, they would go to college. And so I think teasing that out in your, and that may not be possible to tease that out, but I think that's a key thing. Also, another sort of issue that does come up for us is if a state VR agency, for us in Vermont, if we provide direct tuition assistance, the state tuition assistance grant is immediately reduced dollar for dollar. So there's no actual benefit to VR funding tuition for the student. And so it's never as clean as it seems. The last just quick comment was on pre-employment transition services. I just wanted, people keep saying it's for youth. It's not, it's for students, it's for high school students. And it specifically cannot be used to fund post-secondary education. So that's 15% that's actually being taken out of the VR resources to actually fund post-secondary education or any other vocational services. It's specifically for youth, for students. So I guess that wasn't a question. Sorry about that.
Those were really helpful observations and suggestions, so I appreciate it very much. Thank you.
All right. Give a hand to the panel. Come back in 15 minutes.